Welcome everyone to today's webinar on the impact of the COVID-19 pandemic on substance use disorders. I'm Livia Ediger and I'm the Deputy Director of the International Society of Substance Use Professionals, also known as ISSUP. We are an international membership organization with over 11,000 members in 167 different countries. Membership ISSUP is free and we offer 4 different levels of membership. We at ISSUP aim to bring together everyone working in prevention, treatment, and recovery support from around the world, and we provide them with opportunities to access training and credentialing, to build networks, and to share knowledge and learn from each other's work and experience. Our work focuses around 3 main areas. The first one is our website and the digital provision. The second one are our events, conferences, and the third are our national chapters. I would like to invite you all to join ISSUP so that you can access the wealth of information that is available on our website and share your skills and knowledge, and by doing that support other ISSUP members as well and your colleagues around the world. You can access our website and apply for membership on there at www.issup.net. And once your membership has been approved, you will be able to contribute to different sections of our website. For example, the knowledge share section, which works like an online library of publications, summarized journal articles, and information on webinars. On there we have recorded webinars like this one. We are recording this session so that you can watch it again if you want after, or if you want to share it with your colleagues. And we also have information on upcoming webinars on there. You will also be able to share your work with your colleagues in our networks. Our networks function like forums. I would also like to invite you to become a member of our national chapter in Kenya. Our national chapters offer in-country support, and they undertake the work that we do at ISSUP at the international level, at the national level. So for example, they might organize events and trainings, they promote research, and they bring together the drug demand reduction workforce in their country. I would like to introduce our esteemed colleagues from ISSUP Kenya, Evans Oloo and Dr. Richard Gakunju, who will provide you with a short overview of the activities organized by ISSUP Kenya, and will then lead us through this afternoon session as moderators, and will introduce our esteemed panelists. It's really a pleasure for us at ISSUP Global to work with Evans and with Richard. We're very grateful for their work, their continued support, and their dedication to the drug demand reduction field. I would like to thank them both for organizing such an exciting virtual roundtable and bringing together an excellent group of experts. I would also like to thank all of our panelists. Thank you so much for participating in this session today. Just to give you a quick overview of how this will work. So we will have Evans and Richard moderating the session and asking our panelists questions. And then at the end of the presentations, we will have a chance for a short Q&A session. So please do send us your questions. There's a chat function, there's a question function. You can use both. On your GoToWebinar control panel, you can send us questions through those, either questions or chat function, those 2 functions. You can use to send us your questions so that we can ask them at the end to our panelists. Now I would like to introduce Evans and Richard. So Evans Oloo is the president of ISSUP Kenya and clinical director at Intrapersonal Health Services. He's a certified addiction professional with over 15 years experience in the management of addiction and mental health disorders. He has worked for SAPTA, that's the Support for Addictions Prevention and Treatment in Africa, for the Egerton University, Daystar University, UNODC Pakistan, and the WHO MANPA project. He's also a global master trainer trained by Colombo Plans Drug Advisory Program. I would also like to introduce Dr. Richard Gakunju, who is an executive member of ISSUP Kenya. He is the chair of the Global Center for Certification and Credentialing, also known as GCCC. He's also the director of the Movement Against Substance Abuse in Africa. He's a pharmacist with over 20 years experience in substance use disorder prevention, management, and treatment. He's consulted for the National Authority for the Campaign Against Alcohol and Drug Abuse, NACADA in Kenya, the United Nations Office on Drugs and Crime, the United Nations Development Program, the Program for Appropriate Technology and Health, the Federation of Kenya Employers, and he's also a global master trainer trained by Colombo Plan's Drug Advisory Program. Over to you, Richard and Evan.
Thank you very much.
All right, can you hear me?
Yes, we can hear you now, Evans. Yeah.
All right, thank you. So thank you very much, Livia, for the introduction. Once again, my name is Evans Oloo. I am the president of ISSUP Kenya. And as you have said, ISSUP Kenya is the national chapter of ISSUP Global. We do a number of things, but our main objective, which is similar to the one of ISSUP Global, is to bring together professionals in the field, share knowledge, and capacity build so that we are able to provide evidence-based intervention at the prevention as well as the treatment level. I will be your moderator today, and will be together with Dr. Richard Gakunju. We are here basically to try and explore what has happened following the lockdown and as a result of the pandemic that we're experiencing. And it is not unique to Kenya. This is something that's happened to everybody around the world. And we believe that there is a section of the population that most probably has been affected most by the lockdown caused by the pandemic. So today we want to explore some of the possible impacts around that. And we have a very, very exciting, able panel with us. And to introduce our panels, I want to hand it over to Dr. Richard Gakunju.
Thank you very much, Evans, and thank you very much, Livia. It's wonderful to work with you. I am excited to be a moderator in this wonderful webinar. I would like to introduce our wonderful panelists whom we have worked with for many years in the country. And since we are addressing a global audience, I think it will be important for us to relate our experiences to the global arena. I want to introduce Dr. Hussain Mangie. Dr. Hussain Mangie is a public health specialist and a consultant at the UNODC, that is the United Nations Office on Drugs and Crime, regional office for Eastern Africa. He's been there since the year 2015. So he will be speaking a little more about himself, but I'm glad that he's able to join us today, and he will be able to take us through some of the session. The second person I want to panelists I want to introduce is Boniface Ndirangu, who is referred often as Boni. He's the chairperson of the Addiction Prevention and Rehabilitation Association of Kenya, called APRAK. APRAK is a platform in which brings together all rehabilitation centers, treatment and rehabilitation centers in the Kenya, and the owners of those rehabilitation centers come together and are able to form that particular committee. He will also be joining us in a panelist as a panelist. He's a very seasoned addiction professional, and we have worked with him for over 15 years. I will leave the others to be introduced by Evans Oloo.
Thank you, Dr. Gakunju. So far, so good. You can see the experience and expertise that we have assembled, but those are not the only panelists that we have. Allow me to introduce Judy Twala. Judy Twala has a background in psychology. Judy is the manager counselor and rehabilitation at the National Authority for the Campaign Against Alcohol and Drug Abuse, NACADA. NACADA is a government agency set up by an act of parliament to coordinate prevention, education, treatment, and regulation of drug demand reduction in Kenya. So welcome very much, Judy. We are looking forward to hearing from you what the government is doing in response to this COVID-19, especially in the area of substance use disorders. Secondly, I want to introduce Susan Gitau. For many people who work in Kenya, Susan Gitau is a household name. Susan is the Vice President of ISSUP Kenya chapter. She's also the chairperson of the Kenya Red Cross Kiambu County. And she has over 18 years experience in the field. She's one of those few female professionals who has done a lot in the area of drug demand reduction in Kenya. She's also a global master trainer with the Colombo Plan Drug Advisory Program. So welcome, Susan. Last, I want to welcome Sanita Suhartono. She is with the UNODC, a program associate working on drug use prevention and treatment of drug use disorder at the Health and Social Development pillar. Very interesting, because one of the things we are asking is, are services, social services to vulnerable groups being rendered, or have they been restricted? She is currently with the UNODC regional office for East Africa, but prior to her coming here, she was with the office in Vienna. So welcome, Sanita. Welcome all of you. That is our panelists. Great team. Definitely looking forward to a very exciting engagement. And without much ado, I hand it over to Richard. Please take it away.
Thank you very much, Evans, and we will go straight to the point. I know the ground has changed since the experience of COVID-19 came into place, and I want to ask to direct my question to Hussain Mangie. What is the impact of COVID-19 pandemic in essential services and programs reaching vulnerable groups? And in general, all the other groups, but in particular, vulnerable groups. What is the impact on the ground right
now? Thank you, Richard, for your question. I hope everyone can hear me. As mentioned, my name is Hussain Mangie with the UNODC program, regional office in East Africa. And
sorry to jump in. Just a quick interruption. I can hear a lot of background noise. Could you please all mute your microphones if you're not talking? Sorry, Hussein. Please go ahead. Thank you very much.
That's okay. Yeah, I've been working in the field of drug use prevention, drug dependence treatment, and HIV prevention and care in the context of people who use and inject drugs and people in prisons. Regarding essential services, essential service delivery at the MAC clinics and at the community is still ongoing. We are in communication with our facilities and CSOs that we support on the ground to make sure we address any issues as they arise. At the MAC clinics, congestion has always been one of our bigger challenges. And although there have been several efforts towards attaining decentralized dispensing through dispensing units and mobile clinics, challenges of human resources, logistics, and equipment have made it difficult to achieve. However, what we have done is to reduce the number of clients in the facility and to maintain social distancing, as per the guidance pertains, we have established a system of scheduled dispensing in cohorts. Another challenge that we are facing is the lockdown in Mombasa Old Town has resulted in restricted movement, and therefore clients are residing in the area are unable to access mass services that are usually available at the clinics. So therefore, in collaboration with county governments, civil society, including Red Cross Kenya, we have initiated mobile dispensing services whereby clients are now able to access mass services in Old Town. However, this crisis also offers an opportunity to establish and strengthen those decentralized dispensing channels and reduce congestion at the MAT facilities in the future and post-COVID-19. We've also, of course, procured and supplied PPEs to the MAC clinics, our civil society organization partners, and the community, including masks, sanitizers, gloves, and other essential commodities. Communication is essential for continuous service delivery and is especially critical at this time. Clinics and CSOs are in constant communication to provide a holistic approach to the client's treatment and recovery, both at the clinics and the community. What we have done is we have reallocated funding to address these specific needs and enhance communication services, systems, and infrastructure, including providing internet services and equipment at the clinics and civil society. What this means is that this will allow virtual meetings to take place for ongoing communication, coordination, and support. For example, technical working group meetings will still take place. Clinics will still be able to talk to each other, and counties will still be able to receive periodic updates. They will be continuing of sharing best practice, and we're trying to just make sure that everyone is taking part in the conversations that are happening. We have also developed content-specific IEC materials, that's information, education, and communication materials on COVID-19 for people who use and inject drugs and people who are affected by substance use disorders and people in prisons, for which my colleague Sanita will be speaking a little bit more on in detail. For prevention, we also have a lot of resources under our Listen First media platform online, including a booklet and leaflet on parenting under COVID, which includes parenting in refugee settings and in crowded communities. We are, of course, also working with counties to increase access to COVID-19 testing through sharing of information and referrals. I'll pass it on to my colleague Sanita now to speak about the response at the community level and the essential services that are being provided there.
Thank you, Hussein. Yes, in regards to supporting civil society organization, UNODC is continuing supporting them to enhance COVID-19 prevention and also efforts to support treatment adherence in Kenya. We have supported CSOs with container drop-in centers to increase availability and access to harm reduction services, which now also include services that address COVID-specific needs, such as psychosocial support for clients and their families, but also in case any other services are needed, we're providing nutrition programs, hygiene services, and also supporting a women's shelter. We can see now that during COVID-19, there has been an increase in gender-based violence in the country during the pandemic, especially among women who use drugs, including sex workers. They have to find ways and alternative ways to get income in order to sustain their drug use, but also address their basic needs and those of their children. This often results in petty crimes and the need to break curfews to generate minimal incomes. In order to survive, there have been significant rise of abuse of women who use drugs and sex workers. Some have reported mob justice, police violence during curfew enforcement, while others have reported violence at the hand of partners and clients. As Hussein already mentioned, we're also supporting staff and clients with PPEs. We're working closely with counties to increase access to COVID testing. And we also have IC materials that were developed to advocate for clients to avoid sharing of syringes and all other injecting equipments, that advocate for clients to use alcohol swabs before using and disposing of those equipments appropriately. The IEC materials also advocate for clients to continue taking ARVs, OSTs, including methadone and buprenorphine, and to work with their healthcare providers to plan and prevent any disruptions of their treatment plan. The IEC materials also advocate for the supply of naloxone at the facilities, at CSO centers, and the community. In regards to people in prison, in principle, they should enjoy the same quality healthcare that is at least equivalent to the same healthcare that is available in the community, including being part of the response of COVID-19. In this regard, in collaboration with the Kenya Prison Services and Mombasa County health authorities, UNODC has initiated OST services at the Shimola Teba prison to serve prisoners, but also the surrounding community. IEC materials are also available on prevention and control among people working in prisons, but also among people living in prisons. In addition to the existing COVID prevention guidelines, we should also ensure uninterrupted health services for prevention, treatment, and care services for HIV and AIDS, TB, HCV, and other health conditions. We should also ensure a human treatment within prisons through decongesting prison cells and improve prison sanitation wherever possible, maintain prisoners' access to open air as much as possible for at least 1 hour per day by using rotating systems to limit the numbers. We should also ensure continued interaction with the outside world that is necessary for their mental health and well-being. Whenever visits are stopped, and those alternatives should be provided. We should also grant continuous access to legal advisors for people in prisons, as well as representatives of the external inspection bodies. We should not discriminate and stigmatize against suspected COVID-19 cases or people who have had contact with suspected cases, but rather provide medical attention as appropriate. We should also ensure continuity of services and commodities for people with special needs, such as women, elderly, children, non-nationals, illiterates, and people with physical and mental disabilities. Lastly, we should also promote alternatives to incarceration and providing alternatives to conviction or punishment at all stages of the criminal justice system for offenders with drug use disorders. There should be a diversion to treatment, of course, with the consent of the offender. In 2018, UNODC has organized a workshop in Kenya for justice and healthcare practitioners to exactly promote that, promoting treatment and care as alternatives to conviction or punishment for people with substance use disorders that are in contact with the criminal justice system. In that workshop, healthcare professionals and justice practitioners had an opportunity to interact and exchange experiences in line with the SDGs. A national sentencing policy guideline has been developed in Kenya that promotes diversion for vulnerable populations, including people who are affected by SUD, that enables prosecutors to divert cases from the court. The process will allow matters to be settled out of the court on merit and through agreed structures. Recently, Kenya has taken this guidance into consideration and released nearly 5,000 inmates via Skype court sessions. That's it from UNODC's side. And I'll give it back to you, Evans and Richard.
Just before we move away from you, I would like you to mention something to do with the borders. You are a regional office, the UNODC is a regional office, and we have had cases of COVID-19 at the border points and also among the truck drivers. How is this rolling out in view of your interventions?
For instance, we also provide PPEs at the ports for port staff. We have not been involved at the border points, but whereas wherever our mandates are, because we have the container control program, that's where we can support them financially, but also in regards of supplying with PPEs, for instance. Yeah.
Evans, you want to ask anything?
Evans, your
microphone is off.
Can I ask a question, please?
Let us continue. We shall be allowing questions at the end of the sessions. I would like the panelists to give their presentations, and then we can have those questions asked later on. So I'll move quickly to Boniface Ndirangu, who is a seasoned treatment specialist, and Susan Gitau, who works on the ground. And I want to ask you this question, and you can be as broad as possibly that you can be. What is the result of the lockdown? We know that now we have certain cities like Nairobi, Mombasa, are on lockdown. And we know that even some estates are locked down like Isili. What is the result of the lockdown on substance use disorders prevention and management? I can start off with Boniface and then go to Susan Gitau.
A good one. Thank you very much. Can you hear me? Good one. So thank you, Dr. Gakunju and my fellow panelists. I am really grateful to be here. And quickly move on to the question that you've asked. This really caught us very much by surprise, like most the rest of the country. It was really quick and fast and furious. And soon we had to lock down. And we have our regulator, NACADA, who also quickly followed with some regulations as to how it is we are going to operate henceforth. One, that there will be no new admissions. No, that is for treatment centers that are fluid and depend on the clientele that pay to join. No new admissions means no new income. No new income means you have fixed costs that you already have to cover, and if there are no new admissions, so it will affect the general flow of clientele. Now, many of you know that setting up rehabs, Dr. Gakunju, the flow of clientele is a very important aspect. Once the clients leave and you have an empty house, it's a lot difficult to restart again. However, the opposite of it is that we were also not going to discharge anyone because they can't go anywhere. There's a lockdown. So we have two stressors. One, we are not getting any new clients. Two, we have to hold back on clients that are not supposed to have left, you know? And you know that brings in a lot of stress. Three, we have new rules around group dynamics. So we have social distancing, ensuring that you have fewer clients, ensuring that you have less staff. You have one staff handling a week session, and then another staff coming in to relieve that one. So we have less flow of staff into our rehab centers. So a lot of the new rules, and of course, cleaning up after ourselves. Most of you are aware that not all our treatment centers have sufficient water supplies, so we have to have sufficient water, sufficient sanitizers, you know, ensure you have all those increased costs. So essentially, you have increased costs, less number of people coming in, and increased stresses, and less capacity to manage because now you have reduced staff. So those are the circumstances which we have been going through. Yeah. Of course, it has reduced our quality service because the only quality we are able to offer right now is one-on-one. If it is group, it has to be a very small group. To have social distance, and there's not enough staff to handle all the focus groups because we have fewer staff at a time to reduce the flow of people in and out. As you're aware, most of the people are aware here, the panelists, is that a really good other aspect of our program is the comprehensivity of it. That we have visiting doctors, visiting psychiatrists. We have sometimes individual therapists who come in to see an individual client on an individual basis, depending on the individualness of his care. So with the reduction of flow of clientele into the rehabs, yeah, and movement, so they are missing out also on the comprehensivity of care. Most people now don't even want to go and see a doctor. Most people don't want to go to hospital. Doctors themselves are mostly on quarantine, and some of them, if they're out of Nairobi, you can't get them. For people like me, who run rehabs across 4 counties, I've had to stick around to only one area. Usually by this time, I've gone to Mombasa, I've gone to Diani, and I've gone to my other centers. So my work now has been reduced to only 1 county because I can't leave. Yeah. So we are having to use a lot of technology to communicate, which is a good side of it. What else can I maybe add? Groups have been halted. Yes, now we have introduced outpatient. That is very interesting. That's a very nice one, outpatient. A lot of the outpatient programs are new, rather than new admissions, we have more of outpatient programs. We are happy to see things like this evolve, like what we are doing now, and looking at managing people who have been in our centers before, who we can now manage relapse prevention programs through forums such as this that we are having right now. So those are some of the new components. Of course, there's a lot more we've been sharing a lot with NACADA about how they could help us with the basic. I've even talked to Sanita here about it, how we can get some basic cover and cushion that can mitigate against these times, because once these centers are closed, it becomes very difficult to reopen. And of course, now there are obviously other complications about how organizations are registered. Some of them are easily registered under the Companies Act. They're really under Companies Act for profit, but in real terms, if you look at them, it's very little. This field of ours has very little indication to profit making. A lot of the that are admitted usually fall under people have to adjust the prices, sometimes even take other clients for free. So in this field of ours, to set aside a group of people like I represent, 135 rehab centers, we are only registered about 50 so far, but majority of them are very small to be put aside because they are registered wrongly. They're registered under the Companies Act. So those are some of the challenges we are facing with NACADA, and looking through how to help them register in a way that they can get the support of the UNODC, and ISSUP, or the government, for that matter. Unless I've forgotten anything, maybe that is something I would pose my presentation, and hopefully I can add with the questions that come in.
Thank you, Boniface, for that overview of what is happening on the ground in the rehab centers. We know the challenges will provide opportunities too. We are glad that we have UNODC on board, we have NACADA on board, so that some of these thoughts that you have articulated may be picked up and be synthesized in the manner that they should, and also the questions that we'll be getting from other people. I want to hear from a prevention perspective now from Susan Gitau. Susan is involved a lot in prevention on the ground, and if she's online, we would like to hear from her what is happening on the ground. We know the workplace is no longer the workplace. We know people are working from home, and we know there are so many things that have changed in terms of even dynamics of prevention. Please go ahead, Susan, if you're on board.
Thank you, Dr. Richard. Good evening, everyone. Good afternoon, some of us. What is happening now to the outpatient or prevention programs? Number one, after 13th of March here in Kenya, everything went into a standstill. It was a shock to everybody. It affected everybody, not even those who thought they were beyond being affected. So we realized our special clients, especially substance use disorders clients, it was harder for them than for anybody else. What happened was they could not access treatment, outpatient programs. They could not attend their AA programs, their NA programs. Some of them, because of the restriction of movement, could not even access their medication. So initially, the first 2 weeks was very, very tough. And what I noted that was quite bad was that those who had maintained sobriety, I guess because of what now they started going through, the frustration, the confusion, the lack of stability, the fear of the unknown. So most of them went to the old ways of dealing with such feelings or what they were going through. And the old way was to deal by using now substances. So the relapse cases of the people who had been stable relapsed. And a rumor came out, a very strong rumor came out on the ground that since people were using sanitizers and they had alcohol and they could kill the COVID-19 virus, and within themselves they started saying if the sanitizer, which has alcohol 70%, can kill the COVID-19, definitely if I take alcohol, then I'll also get healed. So this rumor went round. So most of the people who had been working with an outpatient program would tell me, no, we are not actually going back to our drinking. We're just taking precaution and making sure that we are not getting the virus. So how are they affected? They were affected because the isolation came in. So they could not interact with the people. The support groups that they had were not there. The social community that was helping them maintain their sobriety or avoid using was not there anymore. So it became very, very difficult for them. They lost employment. Some opted, now that I've lost employment, and I'm feeling bad about everything. So they went back to using. So the fact that they were disconnected from all community resources that were there and the support systems, that really affected the clients who are having the SUD. In a Kenyan setup, we know that the family comes in, it's very strong, a strong social support. Some families even tend to meet every other weekend. It was the Easter thing, people were supposed to meet and have family gathering. This could not happen because of the COVID-19. So major economic devastations are there, they're still there now. People lost employment. The adjustment disorder kicks in due to the uncertainty, what is going on. We don't know how long this is going to be. The fact that people started becoming isolated, and we know that SUDs, they thrive in isolation, they thrive in depression, they thrive in when there's a lot of confusion. So that really messed us up a lot. The fact that they could not even access most therapists at that point in time because of that fear of the unknown. And by then there were no laid plans that addiction professionals were essential services. We were later, I'm also a member of APRAK. Later on, it was realized that addiction professionals are also essential service providers, and therefore they needed to be there. The other thing that I noticed, and I got a few calls about, was that the people who were drinking when they heard about the COVID-19, who are active alcoholics, when they went back home and they could not access the alcohol, they started going into withdrawal symptoms. So they didn't know, the people who were staying with them didn't know what to do. They were saying this person is suffering so much, we are afraid of going to a hospital because of they might go and contract the COVID there. So there was a lot of confusion, and it's still there even now. So we are hoping that with now the media coming in, Kenya Red Cross coming in, so we are really trying to sensitize people and tell them that they need to support the people who are suffering from substance use disorders, and especially the vulnerable one, the women, the younger children, the preteens and the teens who are suffering also, and of course the people with physical disabilities. So we are realizing that addiction, it is a disease. and actually it's thriving more now with the lockdown, and it's not going away. Some people thought that if we lock down, then the addiction would go away. No, it's not going away. It's actually increasing, since the way my colleague Boniface is saying, that you cannot even access treatment. But I like the fact that now there's a way we can go about it, where somebody can be put in quarantine for the 14 days, and then they can access now treatment, unlike before. So I'd want to stop there for now. I give it back to to Dr. Gakunju. Thank you.
Thank you, Susan, for that overview. I think there are quite a number of issues that are emerging and that need as a response. At some point, we shall be asking all of you to give a professional answer or a response to how then do we move post-COVID. We understand that COVID may even be endemic. It may be there to live with us. And so we'll need to revisit things like policies, things like curriculum, things like trainings and all those. But for now, I think because we have NACADA, which has an oversight role over the drug demand reduction in the country, I'll go over to Judy, who will give us a little overview on what they are doing currently. Judy?
Thank you very much, Dr. Richard. I'll give a short overview of what NACADA is doing, or government in general. Like all other nations, I think COVID came as a shocker. It was, it came in a very heavy way. Nobody expected such a pandemic. And like Boniface was saying, we had to come up with some guidelines to guide the rehab owners on issues of preventing infections. So we came up with guidelines with consultation with the Ministry of Health, which we shared with the rehab owners. And I really want to empathize with the rehab owners. It's not an easy time. Like I keep talking to you and encouraging you that we need to adjust so that we can reduce these infections. We have also been doing media campaigns. For those who are in Kenya who watch the main media channels, you realize that NACADA have rolled out a positive parenting program, whereby we are reaching out to parents who are now here with their kids at home all the time. Some of those parents have lost their jobs, like we've heard from Susan and Bonnie, and even to provide the basic requirements for their children or family, paying of rent, food is a real challenge. And now with an additional meal for lunch, now the kids are with us at home for lunch, the budgets have gone high. So people are really struggling. So we have noted that depression has gone high. We've had cases of homicide and suicide in the country. So we have rolled out the positive parenting program, whereby we are talking to the parents and just enhancing their parenting skills, because we know they are the main influencer to their kids, either using or not using of alcohol. The government of Kenya gave a directive to close bars, which was implemented by end of March, but we are aware that some of the bars are still running, operating illegally. So in collaboration with the relevant authorities, the police, the county government, we have been doing some monitoring just to check if people are complying to the government directive to close the bars. Like Susan has said, we have engaged with other experts and professionals who are experts in addiction in different WhatsApp groups, just to sensitize other professionals on issues of addiction. We are very much concerned about the closure of bars, but now people can order beer and other drugs in their house. So what happens to the children? So we really need to educate each other, through the church forums, Muslim forums, professional forums, to let parents monitor what is happening in their homes and what is happening with their children, and also help them to balance what the kids are doing, homeworks, play, make sure that our kids are engaged. So that is the main program that NACADA is doing currently. We are also, in collaboration with the Ministry of Health, rolling out a training on infectious diseases control for the rehabs rehab owners, and that will be done very soon. The government also has been working with the county governments to make sure that PPEs are accessible and affordable for all Kenyans. Of course, at first the masks were very expensive, the sanitizers were very expensive and not even available, but we applaud the government of Kenya for making this a very essential equipment affordable and accessible to Kenyans. The issue of shelter for the homeless drug users is a big concern for the government, which of course calls for a multi-ministerial approach, so that the Ministry of Devolution can see how they can accommodate or provide safe shelters for drug users, the street children during this time of curfew. We also have helpline number 1192, whereby we are marketing it to all Kenyans. It is a toll-free number, so that if you realize that any of your member or of the family or your neighbors are struggling with addiction, you can always call us and we will see how to address that issue and even provide brief interventions through the telephone. The government also has rolled out 719, a number that you can reach out if you see somebody has symptoms of COVID-19. I think the government bodies are working very closely to ensure that the COVID infections are minimized. As NACADA, we are also very keen on monitoring on emerging trends of consumption, trends of trafficking, trends of marketing and promotion, so that we are able to, it will inform us in the issues of changing of policy, because this pandemic will push us as governments to change our policies so that we can incorporate even how to address such pandemics in future, and of course in regards to vulnerable groups. Of concern to us as NACADA is the issue of demand reduction. Like we've said, there is demand. People really want to access rehabilitation centers, but we are aware and we've given these guidelines that you cannot admit until you get a certificate of clear health from the Ministry of Health. Testing for COVID is not cheap. At least now we are happy that the government has brought the charges down. So we are able to refer our clients, our potential clients, to affordable facilities where they can be tested, and when given clean health of a certificate of clean health, they can be admitted in those facilities. We have also been encouraging the rehab owners to enhance the virtual meetings, because we know the role of connection in recovery. So virtual meetings, but we are also aware that some people are in remote areas, whereby right now buying of air connection is not a priority. People are struggling with the basics like food. So we are aware, like Susan has said, and we expect that relapses might go higher. The lack of physical contacts with our loved ones, which is also very important, is very key. And NACADA will be developing messages just to encourage families to look out for the people who are in addiction or who are in recovery. We are also aware that due to the anxieties caused by COVID-19, people will end up abusing prescription drugs as a coping strategy. So we are actually looking out on that, and we are working with the Pharmacy and Poisons Board to make sure that they regulate use of sale of prescription drugs. We also encouraging the general public to understand that it is a difficult time for every sector, for families, for school sector, for security. All sectors have been affected heavily. So if as a Kenyan, you're able to touch a life, even one, in the smallest way possible you can, please go ahead. And also remember, COVID is not a respecter of people. So it is your personal responsibility to be safe and to take care of people that are close to you. I think I can end with that. Then I'm looking forward to interact with the questions and other panelists. Thank you.
Thank you, Judy, for that great overview. And I think it is important to just note some of the very dramatic changes that have happened within the whole household, that people have now moved away from the pubs to the homes. That's why they're using their alcohol, whatever drug of choice they have, and they're exposing this now to the families. So that will be, when we be looking at the way forward, maybe that is something that we need to put our finger on, all of us from UNODC, from NACADA, from the rehab owners, so that we can see how now do we tackle this. I want to move over to Evans Oloo, so that he can be able to look at some of the questions that maybe have been pushed forward, so that we can be able to address them. Evans.
Thank you very much, Dr. Richard. And I apologize, I had to go out. I had problems with my microphone, but I'm back. I was able to catch the discussion. Very key issues have been raised right from the beginning with Dr. Hussein, all the way to what Judy has concluded with. And at this point, I want to open up the discussion to any of the panelists who would like to respond to what has been said, and secondly, some of the questions that are coming in. To start off, I want to throw back to the panelists. I think it was both Bonnie and Susan who described what is going on. What are your thoughts? Because we have described a very nasty situation. There are those who are arguing that the lockdown is good because it is stopping people from going out to use. So what are your thoughts around that? And secondly, what do we see if indeed it is true that the lockdown has restricted the use of drugs? What do we see when the lockdown is lifted? Should we be worried that there will be a surge in substance use cases, in cases of overdose, for example, in the use of prescription medicine? Anyone from the panel can respond to that. All you need to do is just unmute and respond.
Susan, will you start?
Sure. Thank you, Evans Oloo. From where I am, or where I sit, where I'm having a lot of contact on the ground, there seems to be a surge already. And the reason is people are able to order drugs or alcohol to their premises now. So they're still drinking, but in their houses. So if they had a client who was in recovery, and then the alcohol comes into the house, we are finding our clients relapsing quite fast. The use of the prescription medicines are also quite high because people are able to order them, and with our border riders, they're able to deliver. I'm learning from my clients that they are even putting up WhatsApp groups where you can order your poison or whatever you want, and it's delivered to your door with the lockdown. What I'm also picking from the younger people who are not in school anymore, knowing that schools are seriously controlled environments, now they're at home. They're also forming groups within themselves where they can go to one home and use substances there, and they're even putting their pictures on their WhatsApp and some of them on the Facebook to just show that. So people are having this feeling of hopelessness. We don't know what is happening. Some group of kids who had called me were saying, after all, we are all dying of COVID, so we'd rather die high. And it's quite discouraging because there are a lot of people out there who are taking advantage of this situation, and therefore making sure that these things are being accessed, especially when we're talking of alcohol. The bars were closed, but I understand you can still order online. You can still order using your phone, and it's delivered. When we're trying to get to our clients, sometimes it's becoming very difficult because some of them, like Judy said, they don't even have phones, leave alone the airtime to buy the data. The phones, they don't have them because there are other things that they are going through. The mama pimas, or the people now who are selling changa, they're walking around with thermoses, pretending that they're selling tea or mandazis, and yet what they're having inside is actually alcohol. So what I'm noticing that there's a lot of surge because the calls you get, the people who are telling you now, children are using more marijuana than ever before. They are using more card than ever before because they're having a lot of time that they don't know what to do with this time, especially those who are not on online or TV education that has been provided by the government. The other thing that is coming up is that the issue of gender-based violence, whoa, it has gone overboard. IPV, intimate partner violence, has also gone up. The other thing that we are picking, the issue of incest, is coming up. You hear it everywhere. You get calls about it. The issue of other addictions now coming in, where now parents are calling you and telling you now, I don't think it's a drug problem anymore. I think my child is using now pornography more. I think my child is masturbating more. I think, so they're bringing in, they're gambling more. So other things are coming up because of this lockdown, where people are trying to look for pleasure or try to hide from the reality that as it is and trying to feel good about it. So for me, and from where I sit and the people I'm interacting with right now, there seems to be a surge. Even those ones who were using alcohol previously, but they didn't seem to have an alcohol problem, they seem to be now drinking more than they were drinking before. But on the other hand, I hear there's a group of people who said since the bars were locked, they didn't feel the need of pressuring themselves looking for the alcohol, and they have decided, I'm not drinking anymore. So it's cutting both ways. But for me, from where I sit, what I'm realizing is that people are drinking more. And what I'm feeling badly about is that they cannot access the treatment. Unlike the other counseling, virtual counseling, when you're dealing with people with addictive disorders, sometimes they will need to be put in somewhere because of where they are at when you do the assessment. So they're not really people you can just talk to and assume they will stop using, or they can't access, or they'll be able to deal with the issues they are going through. The issue of depression, like Judy Twala has said, so a lot of homicide, people committing suicide, all these things are coming in. So we are realizing the special group SUD, they already had their own issues. With COVID, it's like everything escalated. It just went up. We don't know how to deal with it. I'd want to stop there for now. Thank you.
Thanks, Suzanne. If I may chip in from what Suzanne has just very well told us. We by the way, although I don't know whether you know, I'm also in recovery, and maybe some of you in recovery, the panelists, some of us who also run rehab centers or work in this field are also in recovery. So we are also going through some level of distress, especially because for the longest time, some of us have depended a lot on the support programs of 12-step programs around Nairobi and around Mombasa, and the ones that also happen within rehabs. So you will find the connections. In fact, we have a saying among our program members that our disease thrives in isolation. So now, all of a sudden, we have isolation thrusts on us as the only way out from this virus. I mean, isolate, no touch, no connection, no hugging each other like we used to after the meetings, So there is a very quick shift of the connectedness that we had among ourselves to back into isolation. So this is what I've realized. I've seen even around my neighborhood and from my clients and from what I hear from the other counselors, that yes, with increased isolation and not going for meetings, not being able to access the support systems that are available, there has been like an increase in relapse. It's just that we are not able to go and get them at this time, given the restrictions that we have. Usually I would have just driven off here and gone and met the family and then involve some important people like doctors to get them the help they need. But now we can't do that because of lockdown. Secondly, you're aware that there's a major correlation between our addiction and mental health issues. So mental health issues and addictions are very correlated. Now with these stressors of COVID, increased lost time at home, isolation, no support system, not working, just eating a lot like me here. I've put on some COVID fat, a lot of it actually. What happened is that we start to seek ways to feel better about ourselves. And so unless it is that energy is tapped into a good way of exercising, probably good reading, like online programs. Now that was a good side of it. Online programs have come up, people are exercising more, and some people are keeping a routine. There has been some effort. But without that effort, the likelihood of mental health co-occurring, because not only does addiction be prevalent in our lives, but we also have a lot of these other mental health issues on the sidelines, or they're just waiting. We don't know which one came before which. We will find a lot of mental health issues start to crop up when we are stressed about things like this. This is life-threatening. This is a life-threatening thing that you just don't know when you get it, and if you get it, you're just counting how many body bags. What you watch on TV is just, crazy. If you enter into WhatsApp, that's it. A lot of bad messages about what's going on. Somebody, I've watched this thing come. It has moved from China to Italy to New York. Now it has even moved to my block. I watched it on TV. Now it has come all the way. You're just hearing now there are 2 people in Parklands. There are 2 people in Parklands. Then somebody died just nearby. We had, that person died of COVID. Now those stressors, those kinds of stress. For people who have mental health issues and have addiction issues, the natural reaction is to want to change how you feel, and then the cognitive patterns we have formed in the past, are all geared towards a quick fix. Now that is for people who are in recovery. Now I've seen also my neighbors, some of them who I didn't think they didn't know they have a problem. I've been watching. It's very interesting to see how people can easily shift from abuse into dependence. For that, I think I'll stop there. Thanks, Oloo.
Thank you, Boniface. I can see the other panelists are itching to jump in with something. Before I get to Hussein and Sanita, I want to follow up on what you have said, and thank you very much for sharing about your journey in recovery, and I'm sure you're speaking for many people. You may have mentioned this earlier, but I just want you to give your thoughts. So in terms of support like Alcoholic Anonymous meetings or Narcotic Anonymous meetings, how is that being done? And at some point, Judy had mentioned the connection on social media platforms. Is it a possibility? Is it working? So very, very briefly, what are your thoughts about that? After you share, we will allow Hussein and Sanita to also give us their thoughts, especially what is happening beyond Kenya, because the UNODC has a bigger eye. Is it the same outside? Are people benefiting from the lockdown? Are people suffering from the lockdown? But Boniface, please go first.
Oh, quick one. Yes, I thank you for that. I think now these Zoom meetings have really picked up, but in the first 3 weeks, or the first 1 month, before we got ourselves together to realize actually we'll be locked down for a while, we better get to know how to have a meeting. It was very difficult for many of us, and that is why some of them got lost. But for now, we have quite a number of meetings. I can see one every day in Nairobi at 7. There's another one at 6 today. The Zoom meetings really is just perfect time. And internationally also, I've been invited to speak in a few of them. It's very interesting. They're reaching out. People are reaching out to their alumni, and that is what the association is happening, trying to reach out to their alumni to keep them looped, just sure that they're getting some support. Fortunately, with the new way of communication and new ways of meetings, and we have been left without any other choice. Experiment with this, and it's beginning to really work. And this, I think, we hope that we will take on to the even a post-COVID. Thanks.
Thank you, Boniface. Dr. Hussain and Sanita, what are you hearing outside Kenya? UNODC is within the East Africa region. Are you hearing anything in regard to what has been shared by both Susan, Judy, and Boniface? There are cases of overdose. Are the prescription medication being taken up? What are you hearing?
Thank you for your question, Evans. And I think the context in the region is very similar to what we are experiencing here in Kenya. Unfortunately, Sanita is the one that would be able to give you a better answer because she is working with the partners in the region and the responses that are on the ground. So I think once she reconnects, she'll be able to answer that. But I also wanted to answer your previous question about what are we expecting to see as consequences post-lockdown. You specifically mentioned how there's a reduction in access to these substances during lockdown. And then after lockdown, what are we going to expect as a consequence to this? And I think something that's important to mention is that when there's reduced access to these substances, there's a reduction in tolerance as well. And once the lockdown is lifted and access to these substances becomes more available, then you would be seeing, as a result of that reduction in tolerance, more overdoses. And that's why it's very important to be prepared and observant and be expecting these kind of cases to arise, and to just make sure that everyone is working together to address these issues. Something, if you allow me to just add to what Judy had also mentioned on, and also Boniface had mentioned on the stressors that are happening in the home, in the families, because right now we need to recognize that families are adapting to these changes, and that these are happening because of COVID-19. And many of these parents will find it stressful to balance work, caring for children, and maintaining the household, particularly when they have been separated from their regular support networks. And as Boniface had mentioned, while isolation can represent an opportunity to spend time together and develop your relationships with your family and your children, many caregivers will also be experiencing conflicting feelings and priorities with practical challenges. I just wanted to mention that there are resources available to address these specific challenges, including advice and guidance. NACADA had mentioned a few of them on what they have developed. There are a few available on our website. It basically on how to identify if you are experiencing these stresses, how do you take care of them, and providing insight on what your child may be experiencing and how to help them. But what I think is really important to mention is why are we talking about stress in the home environment, and what is its relationship to substance abuse and substance use? And it's because now there's a lot of evidence that has been able to demonstrate this relationship. And even if you look by definition, drug use prevention, its primary objective is in fact to help people, especially but not exclusively young people, avoid or delay the onset of substance use, and if they've already started using, to avoid the development of drug use disorders. So I just this is something that I felt was very important to mention, and why it's important to address those stressors in the home environment.
Thank you, Hussein. Thank you very much, Hussein. Before I throw it back to Dr. Gakunju, I want to get Judy's view as NACADA. We have described a number of things are happening as a result of the lockdown. And one of the things that we are all worried about, and I believe it's across the world, is that the youth don't seem to be concerned about, one, the infection, and secondly, the effects of alcohol and drug use. As has been said again, it seems to have surged now that we are under lockdown. Is there a problem of messaging that maybe we need to, as both as NACADA as well as other players, that we are not passing across we are passing across one message. Are we failing in passing across the other side of the story, that if we are not careful, we might just have more cases of SUD and mental health issues?
Thank you, Evans, for that question. There's this saying that says there's nothing for us without us. And I believe that most stakeholders have been developing messages for a specific group of people without consulting or involving them. And I think as a Kenyan government or, partners in Kenya, we have realized that gap. And now we have changed. We have brought them on board. We will be developing youth-friendly messages. They will guide us. Which language can we use? The slang language for the slums. We need to use that language to reach that specific group. So I think we really need to enhance our incorporation with for the youth, so that the messages that we are sending out there can actually be received positively. Otherwise, we will just be doing, our efforts will be futile. Thank you.
Thank you, Judy. I will allow any other panelist to jump in on that in terms of messaging. Do we need to sharpen our message, especially as Dr. Hussain has said, in preparation for post-COVID removal of lockdown? We have tolerance levels. Are we seeing potential overdose? Should we refine our messaging? Any panelist can jump in.
If I may, so as I mentioned before, there are IEC materials that had been developed that Sanita had mentioned about, and some of these IEC materials, they speak about avoid sharing of syringes and injecting equipment, using alcohol swabs. This she had mentioned earlier in the call, but also one of those messages that comes out in that IEC materials to make sure that there's adequate supply of naloxone at the facilities, CSO centers, and within the community to be able to address these challenges. So I just wanted to make sure that, when these IEC materials are being developed, that these kind of messages are in there, and these kind of IEC materials are available should, the audience or other panelists or other centers require them.
Thank you, Dr. Hussain. I will hand it over to Richard to pick up more questions.
Thank you very much, Evans, for leading that wonderful session and the feedback that we are getting. Quite a number of things that I imagine that we must be able to respond to now and in the coming few months and even years. I wanted Dr. Hussain to address the issue of medication-assisted treatment. How has that been affected? We know that, like the methadone clinics, they are accessing medication for the clients. How has that played out in this season?
Thank you for that question. And yes, it's a very, our response to that has been that we are working very closely with the facilities. We're working very closely with the CSOs that are supporting those facilities and the community, the clients that are receiving services from the facilities, to make sure that every time there's a challenge that we're able to address it immediately. So like I had mentioned, communication is essential for continuous service delivery. So we're making sure that they're still able to communicate between the facilities and the CSOs, between the CSOs and the clients. And should the clients have any challenges coming to the clinic, like we have in the case of the lockdown Mombasa Old Town, then how can we get the services to the clients? How can we get the treatments to the clients? Obviously, with social distancing, as I had mentioned, we have had an issue of congestion. But we know at this point, we have to do whatever we can to make sure we can try and address these issues. The scheduled dispensing has been working so far, but I think we're very lucky. We have a good team. We have a good team of CSOs. We have good teams in the clinics, and they've been able to really find ways to make sure that service delivery continues as normal.
Thank you very much. I think that gives some insight into in that direction. I wanted us now to look at the shifting ground. We know that a lot of things have changed. We know that we have been using standardized instruments like training materials, like curricula, like treatment protocols. And this in a way will be affected as we move forward. And I will begin with Judy, Twala. How do you think we as the professionals and policymakers should respond to this, and even service providers should respond to this in drug demand reduction, all these changes?
Thank you so much, Dr. I think COVID has come as an eye-opener for professionals and policymakers, because we must review our policies, we must review our curriculum to incorporate such pandemics, because this might be the first one, maybe others will come, God forbid, but we really have to think ahead of time, even setting up a special kitty for emergency strategic approach. So I think so many things have to change as we do our strategic planning, as we do our curriculum. We must be awake to the fact that such crises will occur and reoccur, and they will affect the work that we do and the people that we care for. Thank you.
And how does Boniface see this affecting the treatment now? You have standard treatment protocols, you have certain programs that are so structured, and now COVID is here. We have also mental health issues. How do you see this moving forward?
Well, thank you for that. We have always imagined that out of this, we can activate our technological systems to especially connect data. Now, this is a very good, not excuse, I wouldn't use the word excuse, but it's a very good opportunity for us to integrate technology within our systems. All those things, all procedures, have an integrated system for all the rehab centers. Yeah, through this system that we are developing, like we are communicating now, that at any given time, we are able to host and have a meeting on all treatment. Who are the new admissions? What are the new cases? These are the new training modules. With you, Dr. Gakunju there. Next time we are having a training, we could even have you. That's where you are. You have all the centers where they are having a new procedure. So me, I think community, I really look forward to incorporating this knowledge, our system of care.
Thank you. Maybe we could hear from Susan Gitau again on the same, in terms of curricula, probably. Like, the definition of a workplace now has changed. Workplace is no longer the structured workplace we know of. We know that even vulnerable populations, that definition has also changed. How are we seeing this changing the way we train, the way we embrace this in training? Susan, if you're there. If Susan is not there, Hussein, you can chip in.
Sanita, are you online? Can you? Yeah, okay, yeah. Perhaps you can speak about treatment, care, and rehabilitation for people with drug disorders. Hello? Okay, I can. So
hello?
As we're already doing in Kenya. Hello, can you hear us? Hello?
Yes, can you hear me? Sorry, I had connection issues.
Yeah, we can hear you. I was just about to go into treatment, care, and rehabilitation. Maybe you can speak on that.
Okay, hold on. Let me just arrange myself.
So you arrange your stuff. I would like Evans to be looking at the questions that are coming in so that we can be able to respond to them too.
Thank you, Richard. I want to still stick with the case of the professionals. We have spoken a lot on the persons in recovery, the treatment care providers. I had at the beginning that the UNODC has provided the PPEs to them, but a question that has arisen is with the concern that everyone has, including the caregivers, especially considering the nature of rehab facilities. Should we be worried about the caregivers, the professionals themselves? If so, what steps have we taken? I know the government of Kenya is conducting testing amongst truck drivers, journalists, anyone who is in close proximity to a large population, especially this kind of population. So are there plans, and I guess this is to both UNODC and NACADA, and most probably also Boniface, are there plans to test the caregivers within the facilities? Have we extended the PPEs to them? I know UNODC has mentioned something along that. Has it gotten to the ground? And are there fears? Are you hearing fears from caregivers in terms of how they will go about providing services? So I don't know who goes first. Maybe Judy will allow you to just give your thoughts along those. Then I come back to Steve. Then finally we'll hear from the Association of Rehab Owners. So, yes, Judy.
Thank you, Evans, and thank you for the question. I know we are all concerned about caregivers and the professionals. Hussein has mentioned that they are extending PPEs to the professionals, but of concern to me is the psycho support. Bearing in mind we have caregivers who are in recovery, like Boniface, our brother. What are we really doing to support them? You know, how are we connecting with them? Because most of the times we care for the vulnerable, the very most vulnerable groups, and we forget ourselves. Even we as panelists here, you know, we are affected by what is happening. What are we doing on a personal basis, at family level, at the workplaces? I think we have focused so much on the PPEs and forgotten our mental stability, which is very, very key. And my recommendation is that we need to reach out to each other. I need to call Dr. Richard and just find out how he's doing, how is the family doing, how is your work doing. I need to get to Bonnie, which we do very much. We laugh a lot. You know, let's get a support system, you know, come up with a support system whereby I reach out to you, you reach out to me, and just encourage each other, because this situation will not last forever. Thank you.
Thank you, Judy. Dr. Hussein, do we need to reach out to each other? Have we forgotten the caregiver? I know you mentioned what you're doing, but please, your thoughts.
Yeah, thank you. Thank you for that question. It's a very important question, especially in terms of moving forward and service delivery. So as already being done in Kenya, there, you know, we have to ensure that there's continuity of adequate access to health and social services. As Judy mentioned, there's continuum of care. We have to make sure that these are in line with the international standards. Which is something that's also supported in Kenya, is to address the safety of staff and clients that are receiving these services. Right at this point, you know, we are providing PPE. We are giving the messaging that will give them the protection that they need to receive services and provide services. But we do need to reorganize service delivery to minimize gatherings, train staff, train outreach workers. We need to make sure that the premises of the services that are providing services are clean and hygienic. Whether this be access to hand washing stations, sanitizers, dispensers, all in line with what Kenya is doing. At this point, this is the information we have, and you know, as this information evolves, we need to make sure that we continue to introduce those precautions. People need to be provided with adequate information on the means to protect themselves at every possible occasion. There needs to be a continuation of low threshold services, continuation of pharmacological therapy, as I had mentioned, the availability of naloxone for those who are likely to witness an overdose. And of course, as you mentioned, continuity of psychosocial therapy, whether it be through individual, family, group, on the phone, on the internet, whatever it may be as required. And under no condition should a person be denied access to healthcare based on the fact that they use drugs. This is something that is important to highlight.
Thank you, Hussein. Boniface, have we forgotten the caregivers, the addiction profession of the counselors?
Yeah, thank you so much for that question, because I feel like we have forgotten ourselves and our counselors. Like our centers, like 600 counselors among the rehab centers that we have. I wish, by the way, UNODC, I don't know why they have the only certain people they work with, a certain group of highly vulnerable people they work with, and maybe think that a little bit upmarket, or we are not. We need your support, like PPEs. We need those PPEs. We really need them. Dr. Manji, we really need the support of UNODC, especially in times like this. We need to. There are many of us. And by the way, I had also been calling Dr. Gakunju and the president here, Oloo, in our department for quality assurance, we have requested ISSUP to really play a bigger role in training, if there's any new knowledge. If we are to expand even something like this, you can see we have a capacity of 500. We'll be very happy, Dr. Gakunju and Evans, to take a lead role with the quality assurance and taking care of our staff and the people who help. There are many, about 500. Today is the first time I've sat back to think about them after your question. So, yes, thank you for that. A proper focus would be very ideal, because they take care of these people. And the other thing that helped us a little bit, Evans, is that the moment we learned about the shutdown, we also, since we are experts at quarantine, we quarantine ourselves. We are like quarantine. We closed down admissions. Once we closed down admissions, there was the people who are coming in were the most likely to bring in the problem. That's why we reduced the flow of staff coming in, the flow of counselors coming in, and cancelled all the family meetings, cancelled all the 12-step meetings. So in a sense, a false sense maybe, we protected ourselves. Unless it was already there, it was not going to come. We had reduced the exposure. So somehow there was that less risk unless you're admitting a new client. I don't know whether that makes sense. That's how we were looking at it.
You are absolutely right. I am aware of a facility that immediately after the first case was announced, they stopped their counselors and staff from traveling back and forth because of the risk of getting out of the facility and infecting those within. So you are right, that was a measure to protect the caregiver. I also know of some psychiatrists who moved immediately to online telemedicine as a part of trying to help. So there was an approach, an attempt to protect ourselves. But as we have said, at the same time, having understood what is going on, we ended up denying services to those who needed it the most. A lot has been said about what has happened. I want to shift our attention towards prevention. The WHO says that COVID is here to stay for a long time. So we might as well be accustoming ourselves to the new normal of a COVID world. So how are we going to ensure that the prevention work, prevention for substance disorder, continues in this new environment of stay home, keep distance, and so on and so forth? Prevention. What are your thoughts?
Can I go first?
Yes, Judy.
I think we need to be prepared. Susan has said that from what she's collecting from the ground is that there is already a surge. So I think we need to capacity build the community health workers so that they have the skills and know-how to address persons who are struggling with even the mental illnesses, the simple mental disorders like depression and stress, so that it doesn't develop to substance use disorders. We also want to think we need a shift on our media campaigns, like as an institution. We would want to saturate the nation with messages, right messages in reference to what is happening currently. Those positive parenting curriculum maybe needs to be improved now that we have seen how crisis can affect the family unit. So there are many things that we really need to add into our curriculum. And I think even as government, we also need to really lobby for more funding towards prevention. We really need to advocate for more budgets and calling upon key stakeholders like UNODC to support such efforts. Yeah.
Thank you, Judy. As I shift to UNODC, a question is coming all the way from Lagos, Nigeria. So, and the question is, what methods are you using to create awareness amongst the poor and vulnerable people about prevention? So we are now moving to the poor and vulnerable, those in the informal settlements. So still along the lines of prevention. So what methods are we using? Please go ahead.
Can I say something about that, Oloo?
Please, Susan, go ahead.
What we have been doing, maybe because I'm the chair, Kenya Red Cross Society, our volunteers have been educated on issues of substance use disorders. So when they go on the ground to the vulnerable, when they're taking for them the food stuff, when they're taking for them the masks, so we are encouraging them to talk more about substance use disorders and how they can help those affected, and preferably educate them on the importance of avoiding those substances. Those who are not really addicted, who are just using them socially. And I'm finding feedback from them that some people are really getting encouraged to hear that somebody from Kenya Red Cross is telling them that you cannot use substances, it's bad. And the person is also giving them food and the mask. That seems to be doing, it's becoming a good combination. Though it's not all over the country, we were just trying a little bit with our county. So that can work. The other thing I'm feeling in prevention, NACADA has a very good program for parents and their positive parenting. But we are realizing parents are still very unaware that they're the first line of defense as far as substance use or alcohol use is concerned about their children. So I'm still feeling we need to put in more towards the parents. I'm sure there's no parent who wants their own child to have an SUD. Unfortunately, we have parents who are themselves abusing substances and they don't seem to care what is happening to their children. So that's a very special group. Probably we need to know how to help them so that their children do not end up like them. So prevention, the way Judy said, we need better language to talk, especially to the young people. Probably use younger people to talk to themselves so that they can listen and hear each other, because they influence each other into using. So can they influence each other to not using? So what can we do? Who can we use? Who the young people would listen to? How else can we use the social media? Because currently most of the young people are on social media. What can they be seeing popping up in the social media that is telling them what they are doing, or crossing what they are being told, this works well this way? So could we have counter effect that we put something that the way they're being told about a drug is not true, so something to counter that? So in prevention, especially, we need to go lower in age. so that we capture those ones who have not been exposed at all, so that they are not exposed to the substances, or they can make an informed choice as they continue growing. Thank you, Oloo.
Thank you very much, Susan. I will throw it to Dr. Hussain.
Thank you, Evans. As I mentioned earlier, there is a lot of resources on parenting under the COVID-19 pandemic, and there are also some other documents, for example, some useful tips developed by our partners at WHO, UNICEF, and other international agencies and donors. And some of these cover these life skills that are important interventions that would be useful at this time to address many of the stressors in the home environment. If I can give some examples, it may include how to spend one-on-one time in an age-appropriate way. How do you keep it positive in that home environment, despite the persistent messaging of what's happening out there in COVID? Building structure and routine in the home space, addressing bad behavior, keeping calm and managing stress. How do you have that conversation? How do you talk about COVID-19 with your children? How do you learn through play, like Judy had mentioned? And this is very important. How do you keep children safe online? You know, children and teens are now spending a lot more time online. Being connected helps them. Being connected helps them reduce the impact of COVID-19 and encourages them to continue with their lives. But it also presents its own risks and dangers. How do you maintain family harmony at home? And what do you do when you get angry? What about family budgeting in times of financial stress and parenting in crowded homes and communities? Like I mentioned, we have a resource on parenting in refugee settings and in crowded communities that could be relevant on implementing programs in informal settlements. So these are the kind of resources I think we have to make maximum use of at this time, especially the home environment, to make sure that we have a strong prevention response. There's also a leader's call for action to protect children from violence during COVID-19. The movement restrictions, the loss of income, isolation, overcrowding, and high levels of stress and anxiety are increasing the likelihood that children will experience and observe physical, psychological, and other forms of violence at home, particularly children already living in challenged, violent, or dysfunctional family settings. So it's just important to take all these things into consideration in the prevention response.
Thank you, Dr. Hussain. As I turn to Boniface to give your thoughts, a question has come in, and I think it's partly relevant because you are the chair of the rehab owners. You said earlier that definitely with the lockdown, there was less intake of clients, leading to financial challenge. Everybody across the world is talking about major job losses. We are an essential service. So have you had anything in terms of support? That is the question they're asking. Is there a plan? Is there a rescue plan? Is there what is being offered across to other people that is being given to rehabs and treatment centers to keep them afloat, because they are also they are an essential service?
Yeah, thank you very much for that. Let me quickly just give my thoughts about the prevention and then focus on the other issue. Now, on the prevention side, there's a friend of mine who has developed a program on the education side called Mwalimu Plus. I don't know if any of you have heard about it. It's really very interesting. He's a classmate of mine. He developed this app where now that is what I'm using with my daughter. And I can see that actually her math skills are rapidly improving. We can actually go back to where she has a problem, then she gains her math skills through this app. Very interesting stuff we've been learning as parents also from the COVID issues. Now my thoughts are this, and this maybe is a challenge back to you, ISSUP and content developers of our programs. I think it is possible also for us to develop an app, and maybe this is Gakunju, and you guys need to think about it. We have all the information you need. How do we develop an app that can be used for prevention purposes. We localize it for local content. We develop interesting markers about our children and their behaviors and their predispositions. We have done all these sciences of prevention science. It is possible for us it is very possible for us to develop an app in similar manner. If they are doing it for mathematics, we can develop it for behavioral expectations or behavioral indicators that can tell us. And since we have time, we can follow through. We can follow through with people to know how it turns out, what interventions are put in place, and how they shape up. My thoughts, and maybe a challenge back to you, ISSUP, and the content people. Back to my other area, my other question on the finances. Yes, the first thing we knew, yes, we are operating at half capacity. We're not even operating at half capacity. Right now, we're operating at about a third of capacity, a bare minimum of capacity, just to survive. Yeah, and mainly because of the lockdown also, we still are keeping the clients that we have. And depending on the centers that you run, you're also getting problems with cash flows, because you know, anyone who has a financial problem, we people who have an alcohol drug problem are usually the last money to be spent. And we are disposable. If problems really happen, come together, so many of them, we are the first ones to be cut off. You know, so most treatment centers and payments that are done through for rehabilitation, if people are having a problem with food or with medicine or with rent, we will be the first one to miss out on the payment. So majority of the payments have really gone down. Yeah, we have applied to NACADA. Fortunately, we have a very supportive CEO and NACADA authority. We have also written to Sanita here and UNODC. I've also met the chairman of the parliamentary commission that deals with the budgets for the coming year. We are hoping that we can listen. We have done a small budget, and this is where we, even Dr. Hussein and Sanita, can really look through. We rehab centers are not asking for profit or to be funded for profit. No, I am a finance person. I'm an MBA in finance, by the way. I do not think we are going to ask anyone to make rehab centers and rehab people who are managing rehab rich. No, but we can cover to the tune of the running costs. And that means for exchange, tune to the running costs is just rent, salaries, electricity, water, and food. Basic. Yeah. And then they have an obligation to provide services to the community. They have an obligation to fill in information. This has been we are discussing this so that at least people know that these treatment centers are really not making money, because I mean, if you really want to make money, you can't be in a rehab setting. Rehab setting has no money, really. If you want, yeah. So if you want to make money, that is not the field. But because they provide a critical service, an essential service, we can have a fund through which these people, in case they're about to close down, can be supported to survive. And in case the management is not doing very well, it can be taken over by the association, but to continue providing the same service. The same service for vulnerable people or people who have an addiction problem, who are essentially probably forgotten, because there are quite a number of the population, Dr. Hussein and Sanita, that we forget. When I realize this, Dr. Gakunju, also maybe this is something, and Oloo, you can also support. Many people who live in the deep slums, in the slums of Nairobi, they get a lot more support of the international organization than people who live in Zimbabwe, Jericho, and they are equally poor. They are equally not well doing. But because the target, the whole world's target is on the very down, these people are forgotten, but they really need that support. Really need that. Does that make sense what I'm trying to say?
Absolutely, absolutely. Thank you very much, Boniface. A challenge has been thrown to both the government and the donor agencies to think about how to support rehab facilities because they are essential services. As we slowly come towards the end of this webinar, and I will want each panelist to think of what you will be telling us as your final thoughts, both in terms of the way forward and, like I said, the final thoughts. A question has come here, very interesting question. I don't know who can respond to it. And the question reads, many people have been infected and died as a result of COVID-19. What is the prevalence of those with amongst drug users in treatment centers? Are there any cases of mortality reported as a result of COVID-19? Anyone with information about? Yes, Hussein, please go ahead.
I don't have that data on me. Like I said, I don't have that data on me, and I know that there have been some cases of health workers who are working in facilities that have been infected in Nairobi. But at this point, I don't have enough data to confirm if we have any of these cases. However, we are, like as I mentioned, we are in constant communication with the clinics and CSOs to ensure that there is continuous services, and if there are any of these cases, to make sure they get referred so that they can get the appropriate treatment or appropriate testing required.
Okay, thank you. And any other information, and most probably today that come from NACADA, who do a surveillance around these things.
As NACADA comes in, yes. As NACADA comes in, there is also another question that asks. This from Sweden. Somebody says that the lockdown led to the reduction of the inflow of many of the drugs, psychoactive substances, and there was also the disruption in the supply chain. This led to an increase in crime, either within the streets or in the homes. How are we managing that in our country? That is the question. Have we seen an increase of crime related? Of course, some of you have alluded to that in terms of the crime that we have, the violence that we have seen in the homes. But among the users of other psychotropic, psychoactive substances, have we seen that? Because how has the supply been maintained? Because there's a lockdown. That's, I think, is a good question that needs to be answered. Maybe you could start off with that, and then we can move on. And I think Hussein would be a good person, and Judy, to answer that question.
I don't have this information on me, I'm sorry. But what I can comment on is what I said earlier, is that, you know, yes, there is a reduction in access to the substances, but there are also consequences to that because of reduction in tolerance. I know there is an increase in gender-based violence cases as a result of the curfew and the lockdown. I really wish Sanita could be able to comment on that. I'm not sure if she's online.
Let me try. Can you hear me?
Yes.
Okay, perfect. So yeah, as mentioned earlier, we are supporting a CSO who runs a women's shelter in Mombasa in providing psychosocial services and also supporting them in advocacy by, you know, providing stickers for the Boda Bodas who are referring these women who need support. Those are women who use drugs that are affected and exposed by gender-based violence, because as I mentioned earlier, with the curfew and also yeah, with petty crimes now, they still need to generate minimal income. That's why they are engaging in petty crimes. What we're doing also is trying to support them in giving trainings for the healthcare workers, for the outreach workers. But yeah, I mean, I think everyone is struggling with funding now. For us, we're just trying to advocate what is under our mandates, and also trying to reallocate funds, as already mentioned earlier.
Maybe Judy can go. Judy can go, especially on the question about there's a lockdown, but drugs are still being supplied. Then Boniface, you will jump in. Then we'll have one final question, after which we'll take a round from the panelists on your final thoughts. Judy, please.
Thank you, Evans. Maybe I would just want to give an example of one of the small towns in Nairobi, Dagoretti, where I had a session with some active drug users, and they said crime will increase because they were struggling with money to get basic needs like food. But then there was this directive that everybody should wear a mask. So for them, they were telling me masks are like hotcakes. So if you just passing by there, they will snatch your mask because they didn't want to be arrested. So those petty crimes, I'm sure, will increase because people have to provide for their families anyway. The issue of supply, maybe I'll just refer to what I'd said earlier, where people are dialing and getting these drugs at the comfort of their houses, and even alcohol. So yes, I think the supply has not been, I don't think it has really been affected as such.
As a rider to that question, Judy, how do you see a policy change in terms of access to alcohol, especially in the homes, through the what you call it, online ordering? How do you see that changing in the policy?
Thank you, Daktari. I know there is an active discussion in regards to that topic. So I may not be in a position to comment now, but maybe once a decision is made, I'll be able to communicate.
Thank you. Boniface, you wanted to say something? I'll give you 1 or 2 minutes.
Oh, yeah. Very briefly, I think, yeah, with regard to crime, I've had in our neighborhood a little concerns around that, break-ins or something like that we should be extra careful. But this is what I've also noticed on behalf of our chief in our area, because I visit him often. I noticed that they have a system of distributing food to the most vulnerable. So I don't know, maybe we expected slightly higher rate of crime than actually what is happening, maybe because the government is really distributing some food through the most vulnerable people. I would think, because it has not been as bad as it was expected. Or maybe I just live in a neighborhood that we don't have a lot of.
most probably live in that kind of neighborhood. So, but thank you anyway for the observation. My last question was a question that came earlier, and it goes to Sanita. The question was to provide a broader picture of what is going on outside Kenya. You work closely with those in Tanzania and Uganda, and I think the question has come from one of those countries. How is the situation? What reports are you hearing, and what are you doing?
Thank you. We're working at the regional office of UNODC for Eastern Africa. We are in close contact with colleagues in Tanzania and Ethiopia, and we're working closely with other UN agencies like the UN Joint Team for HIV and AIDS. For Ethiopia, for instance, we are in contact with the UN Joint Team that has also supported the Ministry of Health in writing a guideline to ensure the continuity of services for people who are affected by substance use disorders, but also for people living with HIV. There, we're also providing PPEs for prisons or people living in prisons, but also prison staff. For Tanzania, we are in contact with the DCA and working together to ensure that MAT clinics are supported. There, we're also in close contact with the UN Joint team in Dar es Salaam. And yeah, so I mean, we're trying to support whenever we can. Basically, the same needs. We're supporting people who are using drugs, people who are injecting drugs, and people in prisons.
Thank you very much for that. I guess with that, we basically come towards the end of this webinar. And like I said, I will want to hear your way forward. I will give each panelist 2 minutes or a minute if possible. What would you like to tell those who are listening, those who are tuning in terms of what we should be aware of, what we should take away with, and what is critical as a way forward? And I will start in the order of introduction, but from the last person we introduced. And that means I come back to you, Sanita, to give your thoughts, and we shall go in the order of the introduction we had. Please go ahead.
Thank you. I guess my intervention will be together with Hussein since we're working for the same organization. But yeah, we would like to ensure that we're still continuing to implement activities that are planned for 2020 under our work plan, while of course taking into consideration the impact of COVID-19 and how we can expand and tailor the activities to accommodate the COVID-19 response. We're also working, as already mentioned, with other UN agencies under the UN Joint Team for HIV/AIDS, for HIV in context of COVID-19. But we're also working in collaboration with NACADA, with APRAK, with Judy and Boniface, where they're implementing a UNODC WHO facility survey to assess drug treatment facilities and also provide general mapping of available health services. As also mentioned, they should be included in essential services in the country. In terms of coordination, that is now happening online. That was also mentioned in the call already. So through platforms like WhatsApp, regular online meetings are happening with our partners. Also like webinars like these are also happening. And lastly, we're currently planning a policymakers training in collaboration with the Ministry of Health to support a better coordination and collaboration in response of providing adequate intervention in drug use prevention treatment of people with substance use disorders. We're also, we have been conducting some assessments, which my colleague Hussein will further elaborate. Thank you.
Sorry, Evans, we can't hear you.
Evans, we can't hear you. Okay, Evans, we can't hear you. So we'll go to Judy and listen to her last thought in terms of way forward. Judy? Okay, we can't hear Judy. Susan Gitau?
Okay, can I go now?
Yes, please.
Sorry, I was muted. I'm saying that COVID-19 is a real crisis that has affected all sectors, and it demands a multi-sectoral approach. So if we put our hands and our brains together, we will overcome. and also to encourage that we reach out to one another. And remember, we are the voice for the voiceless, so we'll keep advocating for interventions that can make their life more tolerable. Thank you.
Thank you, Judy. Then we go to Boni.
Yeah, well, thank you very much. And by the way, thank you very much, ISSUP, for organizing this. And it's awesome that, and maybe this is also the side benefit of COVID side benefit that it has brought us in a way that it has developed a way in which we can actually meet and communicate and plan, yeah, and strategize, yeah, at a very low cost, almost very low cost. Yeah, it should have taken quite a number of 100,000s to get us together. But at a very minimum cost, we have brought in really brilliant minds together to discuss important things. And I can see quite a number of attendees also. Thank you so much for attending. But this is my point, Dr. Gakunju. If possible, if we can build on this a little more constructively in terms of technology, so prevention. How do we develop a prevention program that uses technology? Because there could be a pandemic another day, and even without the pandemic, even without it, it's very low cost effective. It can be used smartly to reach to many people. So if there is anything that these times have provided, flexible work hours, distancing, but able to meet and communicate online, and through the same we can develop training programs that are cost effective. We can have through this system and ISSUP training for all our rehabs without meeting. Every morning, 1 hour, we have a meeting. What is a morning meeting? What are you doing in the morning? How are you managing? You know, we are increasing value. So in a way, given the distance that we have, being forced to be separate, we have been opened up by COVID to use technology in our area of work. I think that's a big one for me. It is also an opportunity for us to be as creative as possible, you know, with outpatient programs, because a lot of our ways of doing stuff has always been very rigid around, or you get somebody, put them in rehab, you know. We can now start thinking about our patient. What are the outcomes really we are looking at? It doesn't have to be that people are locked in somewhere. Yeah. So those are some of the interesting stuff.
Thank you very much. I think we have we have run over time, but we can have 1 more minute for Hussein and Susan.
Yes, Richard, I'm here. You had muted me. I'm looking at it from the caregiver's point of view. I feel probably we should have better ways of helping them deal with the new normal, the caregivers themselves, supervision, whether virtual, on the Zoom, or like what we are doing. Also the need for them to be also well protected, sanitizers, maybe they need the PPEs at one point or another. So my thoughts as I end this is the caregivers, self-care, how to be better so that they can also give better quality treatment plans for their clients. Thank you.
Wonderful. Hussein, you have the last word, and then we move to Evans before he answers over to Livia.
Well, thank you, ISSUP, for providing us with this opportunity to speak on this very important subject at this unprecedented time. It's good to be back on a panel with familiar names and faces, working with partners together again. I just wanted to comment that, as mentioned by Sanita, you know, we're going ahead with the activities that we planned for 2020. For example, we're planning to conduct a substance use assessment with Kenya Wildlife Service with the support of their Corruption Prevention Committee, similar to an assessment that he had conducted with the National Police Service in 2018, and potentially one in refugee settings in the future. In the response to this pandemic, I think there should be good coordination and collaboration among our partners for a concerted response. What we do not want is duplication of efforts and wastage of resources, especially at this time. professionals in their capacities should try to continue, should try to ensure continuity of service delivery and work together with policymakers to participate in the right conversations and the right discussions to ensure that there is inclusivity of key populations. I need to emphasize that we need to work especially closely with civil society, since they are in the communities and they are the ones who know what the needs are on the ground. Just wanted to leave it at that.
Evans? We can go back now to Evans to give us the last word as the president of ISSUP Kenya, and also give thanks to all of you, UNODC, APRAK, NACADA, and ISSUP Global for a wonderful job, and we look forward to more webinars like this. Evans? Can't hear. We cannot hear Evans. Okay, then I think we'll hand ourselves over to Livia, who will give us the last word. And Livia, are you on?
Yes, I am on. Thank you very much, Richard. Yeah, I'm sorry, Evans should be on. I can see that he's connected. I'm not sure what's happening right there. Thank you very much, Richard. Thank you very much, Evans. Thank you all so much for participating in such a fantastic and interactive roundtable with really stimulating discussions, with a lot of like informative discussions and great information and updates on the impact of COVID-19 on substance use disorders management and prevention. It was really exciting to see that so many people joined us, people from all over the world. We have received many messages from people in Kenya, in Argentina, Canada, Mexico, Norway, Nigeria, Togo, Sweden, the UK, and the United States. I'm sure there were more people on there, but just those were the messages that we received. We thank you all very, very much for sending us your thank you notes, and we received congratulations from all over the world. So thanks very, very much to our esteemed panelists, to Judy, Susan, Sanita, Hussein, Boniface, and to our moderators, Richard and Evans. We very much look forward to organizing and co-organizing and hosting more of these events. I think this was an excellent opportunity. And we noticed obviously that we had a few connection issues. Thank you very much for bearing with us. That's the nature of holding live webinars. And unfortunately, it's not under our control, and especially with the connectivity. Friday afternoon might not be the best day, and I think we'll probably choose another day next time, but thank you so much. For those of you who want to re-watch it, if you had problems with your connectivity, this will be available. We've recorded it, and you can share it with your colleagues, or you can watch it again on our website. We will send you all a follow-up email, and since it's Friday, it will come at the beginning of next week, and you will receive the link and any information on upcoming webinars that we are planning together with ISSUP Kenya and our other chapters. So we really, as I've mentioned before, we invite you to become an ISSUP Global and an ISSUP Kenya member, especially for those who are in Kenya. We encourage you to sign up for ISSUP Kenya so that you can receive information on the activities that are organized in your country and in your region. Thank you all for participating, and stay safe. I look forward to seeing you again next time. Thank you.